Attention Deficit Hyperactivity Disorder, or ADHD, is a behavioral and developmental disorder of childhood that often persists into adolescence and adulthood. Millions of school-aged children, at least 1 out of every 20, suffer from this disorder. These children are also at increased risk for school difficulties, problems with friends, and conflicts at home. Over their lifetimes, many of these children also suffer greater problems with substance abuse, other emotional difficulties, and problems at work and in relationships. Nearly 5 to 10% of all school-aged children suffer from ADHD, and of these, 70% will retain the disorder into adolescence. ADHD is 4 to 8 times more commonly diagnosed in boys as compared to girls. Girls are apt to be less hyperactive and therefore less likely to be referred to treatment. In adults, the ratio of men to women is approximately 1.6 to 1. ADHD has been associated with structural and functional brain differences, especially in the frontal lobes, striatum, and cerebellar regions. The frontal lobes help us evaluate choices before making a decision, and the striatum converts impulsive thoughts into actions. The cerebellum is involved in coordination of complex activities. These areas of the brain are linked by neurons, or brain cells that form a circuit, and communicate through neurochemical impulses. These impulses are carried from one neuron to another through chemicals called neurotransmitters that are released by neurons into the synapse, or the space between two connecting neurons. Norepinephrine is linked with attentiveness, learning, memory, and mood. Dopamine affects the way the brain controls movements and activity. Dopamine is also associated with memory, attention, and problem solving. Scientists believe that these neurotransmitters are involved in the pathophysiology of ADHD. Heredity is the most common risk factor for ADHD. The heritability of ADHD is in the range of 80%, making the condition almost as heritable as height. There is about a 35% chance that any child with ADHD will have at least one adult with ADHD. Fetal exposure to toxic substances during pregnancy, for example, a mother who smoked and consumed alcohol during pregnancy, or childhood exposure to lead, have been associated with increased risk for developing ADHD. Premature babies born less than 32 weeks gestation, or with birth weight less than 1,400 grams, also demonstrate increased risk for ADHD. ADHD is not due to a child having low intelligence or being lazy. It is not due to external factors such as poor parenting, excessive television viewing, or diet. ADHD is characterized by inattention, hyperactivity, and impulsivity that are particularly severe when compared with most same-age individuals. Children with ADHD exhibit 6 or more symptoms of either inattention and/or hyperactivity or impulsivity as defined by the 4th edition of the Diagnostic and Statistical Manual of Mental Disorders, or DSM-4. These symptoms generally cause difficulties in multiple settings such as home, school, or with friends. Hyperactive or impulsive symptoms are generally detected prior to the beginning of school. Symptoms such as inattention are often not evident until age 8 or 9, or even later in some cases. The inattentive type of ADHD is typified by children who have difficulty paying attention to small details and who often rush through their work and make careless mistakes in school. For example, they might lose points on tests because they fail to read directions properly or do not complete both sides of a handout. They also might have difficulty listening when spoken to directly and might not follow through on instructions, particularly with complicated tasks. They often have difficulty organizing tasks and activities and avoid work that requires long periods of mental effort. They might frequently lose toys, books, and other belongings. They can be easily distracted by extraneous stimuli and often forget routine tasks. Parents often become frustrated when homework takes much more time to complete than expected. Children with a hyperactive or impulsive subtype of ADHD often fidget and squirm in a way that is annoying to others. They are frequently restless, particularly when bored or unchallenged. This may manifest in the form of finger drumming or shaking legs. They are frequently unable to remain seated for long and may indulge in excessive running and climbing. They have difficulty in playing quietly and tend to talk excessively. These children may blurt out answers before questions are completed, and may have difficulty standing in line or waiting their turn. They are prone to interrupt and intrude on others, even when they are busy, such as when parents are speaking with someone else on the telephone. On the playground, they might engage in risky or unsafe behaviors. Children who exhibit both inattentive and hyperactive or impulsive symptoms are characterized as having the combined ADHD subtype. Manifestations of the disorder usually appear in most situations, including at home, in school, at work, and in social situations, but to varying degrees. Symptoms usually get worse in situations demanding sustained attention, such as classrooms. Children with ADHD often display academic underachievement, regardless of their intelligence. Without treatment, these children are at increased risk for developing low self-esteem around school issues. These children are often rejected or receive negative attention for their behaviors, and consequently develop feelings of inadequacy and failure. Similarly, children with ADHD often have difficulties sustaining friendships and developing skills necessary for getting along with others. This creates additional pitfalls in which ADHD children are more likely to become involved with delinquents or conduct disorderly activities, as well as have problems with tobacco, alcohol, and other drugs of abuse. ADHD is generally diagnosed by child and adolescent psychiatrists, child neurologists, pediatricians, and clinical psychologists. The child should show symptoms persistently over the previous 6 months, and the behavior should be more severe than children of the same age. These behaviors should be exhibited in more than 2 settings, such as at school, home, daycare, or in social interactions. The behavior should impair the child's ability to make friends, to progress at school, or to get along with parents or siblings. Clinicians generally meet with parents and child to get an overview of the problem and assess developmental, medical, and social history. It is likely that parents and teachers will be asked to complete several behavioral rating scales to help the clinician assess the child's behavior over multiple settings. Tests of intelligence and learning achievement might be performed if there are concerns about other potential learning issues. It is usually assumed that the child has had normal pediatric care and that general medical conditions, such as vision or hearing problems, have been ruled out as the likely cause of symptoms. Medication is the only treatment that has been shown to be effective in reducing the core symptoms of ADHD. In most cases, a clinician will recommend medication as part of a comprehensive approach to helping patients and their families address the disorder. Psychosocial treatments such as parent management training, behavioral charts, social skills training, and accommodations at school might also be helpful and will be discussed with the family after careful consideration of an individual patient's needs. Parents of children with mild ADHD-related difficulties might choose to delay initiation of medication therapy. This is a reasonable option to discuss with the treating physician, but a trial of ADHD medication is usually warranted if the child is suffering from observable impairments. Medications for ADHD are effective in controlling symptoms in the great majority of patients. The most commonly used type of medications for ADHD are classified as stimulants. These medications increase the levels of neurotransmitters in the brain. Some commonly used stimulants are methylphenidate, dextroamphetamine, and mixed amphetamine salts. The common side effects of stimulants are decreased appetite, headache, stomachache, irritability, and insomnia, although many of these side effects occur in ADHD children whether or not they are receiving medication. Antidepressant drugs like tricyclic antidepressants, venlafaxine, and bupropion are sometimes prescribed for reducing hyperactivity and improving attention, since they also increase the levels of neurotransmitters in the brain. Side effects may include dry mouth, blurred vision, or drowsiness. In general, physicians will only try non-stimulant medications if a patient does not do well with stimulants. Currently, atomoxetine is the only approved non-stimulant, but other non-stimulants will be approved soon. Atomoxetine is a selective norepinephrine reuptake inhibitor. It strengthens the neurochemical signal between the neurons that use norepinephrine to send messages. Common side effects are headache, abdominal pain, nausea, vomiting, weight loss, anxiety, sleepiness, and insomnia. The doctor may try different types of medications at a variety of doses to determine what is best for the child. Ongoing use of medication is often necessary to help the patient reduce the risk of long-term problems often associated with ADHD. Taking care of a child with ADHD can be demanding. Siblings may resent the impulsiveness and other behavioral problems of the child with ADHD, and also the child receiving a greater share of the parent's time. It is important for the other members of the family to understand the child's differences. Set a routine for the child that includes a regular mealtime, studies, watching TV, playing, bedtime, and wake-up time. Each family should find the schedule that suits it best, but all children benefit from consistent expectations and routines. Children with ADHD generally respond well to parenting practices that benefit all children. Help the child organize his or her school bag and keep a diary for daily activities. Make sure the child has a quiet place to study that is free from distractions like traffic noises or street sounds. Use simple, direct commands for giving directions. Avoid long explanations. Be calm even when the child is out of control, and speak in a reassuring tone of voice. Do not yell. Instead, withdraw privileges as a consequence of unacceptable behavior, and more importantly, find ways to reward behavior that you approve of. Talk to the child's teachers at school and obtain daily feedback. Inform the teachers about the child's condition and ensure that the teachers provide the understanding and support required by the child. If medications are prescribed, ensure that they are given in the correct doses to the child at home. It is important to set realistic goals, both for the child and the parents themselves. Focus on the good aspects of the child's personality and try to stimulate them through positive reinforcement. Other interventions apt to be useful in school include a seat assignment close to the teacher, extended time on tests, taking tests in a quiet work area, getting breaks during exams, and modified homework assignments. These interventions are inexpensive and easy to implement, but should be applied on an individual basis after discussion with a child's school.